majority of our programs running at their existing levels. So of that 5.81%, 5.34% of the general fund is going directly to the current services. What we see is the majority of the current services pressures really are in caseload and utilization, and in movement of one-time funds from side letters from the Department of Corrections that have helped us move from a 30% vacancy rate down to a 17% to 19% vacancy rate in their correctional facilities, moving those into the current collective bargaining agreement. And I'll go into more detail about that in a little bit. Overall, the Agency of Human Services has 3,835 employees, and we have increased in size by 0.2%. When we think about our base initiatives this year, there are very few, and the few that we do have are really focused on filling gaps that have been identified in our systems in the last year, and particularly our substance use treatment system, and beginning to expand and bring programs to scale that have evaluated and are showing success. And that is our pretrial supervision program. We also are moving past initiatives from one-time to base. So you've seen a theme over the last few years at really working to address mental health and substance use in a co-occurring way. And so what you see here is us moving what is often called our alternatives to emergency departments. Many people urgent care from one-time funding that we've had from Medicaid through some advanced federal funds over and into the base. In addition to that, it's taking the shelter expansion that we've done over the last year. These are intended to be permanent, year-round and seasonal shelters, and ensuring that their operations continue. So we're moving those from one-time to base. In addition to that, the one-time funds that we have requested really are focused on startup for our initiatives and addressing what is coming as a gap in primary care funds as we move from the all-payer model to the AHEAD model, and then also continuing PCB testing. So nothing new, but supporting the broader initiatives that are already moving forward. So that's a broad overview. Again, it's primarily a current services budget, keeping the lights on, and really trying to fill gaps in our systems of care.
So, Secretary, what is the increase in costs? I'm presuming it's health insurance. I know it seems like it's the Agency of Digital Services has got some big cross-departmental charges happening.
So let me walk through. I'll walk through those in more detail if I might share. Again, as we move forward, just as a recap, this is where the funds for the agency are appropriated. What you might note is that global commitment really is the amount of money that is the general fund that we can then match with the federal funds. That sits in the Secretary's office and then is allocated across the agency to implement the broad Medicaid programs. And so that's across DVA. It's across all of our departments, particularly DVA, Department for Mental Health, Department for Disabilities, Aging and Independent Living, and Department for Children and Families. So our total
income.
I question on the previous slide, which has, if we go back just one.
Yeah.
Yeah, just with the moving from the temporary shelters to the full-time year-round. Is that happening universally across all of these temporary shelters that have been stood up in the past?
So last year we were provided with one-time funds, and those one-time funds were many of our community organizations, like our Office of Economic Opportunity, like Vermont, like Champlain Valley Office of Economic Opportunity, and other agencies who provide sheltering and housing proposed shelters this year, with that one-time funding. It's it's in a variety of communities across the state, and the Department for Children and Families will be coming in to walk through their budget. They can give you the detail on where those shelters are, but it was the intent of those organizations to meet the needs that are currently in their communities for the long term, not just for a year. And so those are continuing.
Yeah, that's great. So I think maybe the DCF presentation would be super helpful to have laid out which particular shelters are going to be continued from the temporary to the, and just, how those decisions were made.
Yeah, it's not a decision about which ones are and aren't. All of the shelters that proposed expansion in this year are moved from one-time funds to base in the coming years. So we didn't make decisions about winners and losers. All of the organizations who proposed and mounted community-based shelters are continuing for the next year. They can cover where they are.
Yeah. I don't know if maybe there should be more discussion as well. Maybe that's something to address later.
FDCF.
Yeah, totally. Thank you.
Yeah. So again, there's a 0.2% increase that overall in the agency. That's new. There are some positions that move between departments, but overall that's 6 positions, which is a question we often get. Okay, so Chair, please let me know if we don't answer the questions here. But with our current services pressures and that 5.34% increase, the majority of it is in our Medicaid consensus for $51 million gross. That's a combination of utilization and caseload. And this coming year, the major change is in utilization. And it reflects what we've seen this year, rolling forward from our into next year. So we don't anticipate utilization will go down compared to this year. We also have federal and state mandates for rate increases. And so the nursing home statutory rate rebates and inflationary costs is included here. The nursing home bed utilization, and as we came in and discussed the BAA, or at least the departments did, what you saw is us returning pre-pandemic levels. So during the pandemic, we had a significant loss in the total number of open skilled nursing beds or nursing home beds in our state. And this is rebounding back to our pre-pandemic levels. We continue to see a strong community-based system with the majority of services provided in the community.
You provided me an opening to ask about that. I'm familiar with what's going on with the nursing homes, but I don't see anything in current services pressures that address any kind of cost of living increase for the home and community-based side of things.
So what we have in the work that we did with our budget this year and the where we needed to be, what we identified is that we looked across our services and we saw that organizations like our designated agencies, a vast majority of them are healthy financially and some are not. The same thing with our federally qualified health centers, where we see federally qualified health centers who are financially stable and some are not. What we've identified is that there are potential structural issues. And for this year, left with a decision to cut services to Vermonters or focus this year on addressing structural issues, we chose to move forward with working with those organizations across Vermont to look at how we could fix the structural issues rather than pull back services. There was definitely consideration. There are Medicaid services that are not required by the federal government. And one of the options in order to increase rates for our providers had been to eliminate or reduce some of those other services, and we chose not to do that. So in addition, the other place and space that you see it is adequate funding for the DOC and yet the Department of Corrections collective bargaining agreement. And with our collective bargaining agreement, we've had side letters over the last couple of years that were one-time funding. In the bargaining process this year, those were moved from the side letters into the actual collective bargaining agreement.
Does that include, oh, go ahead, Representative Donovan. Go ahead.
I was kind of fermenting on the prior discussion. I wanted to go back briefly there and looking even at the sheet where it's talking about current services pressures, and that increase addresses current services needs. And I keep thinking back to the governor's budget address where he talked about increased revenues, but much of that being taken up by maintaining current services given inflationary pressures, not leaving a lot for, new initiatives or other things people wanted. And what I didn't hear in your response is when we're talking about current service pressures and current service needs, in order to maintain the status quo of services given inflation, how can that not include things like designated agencies, home and community-based services? Selectively, they are being removed from in order to maintain status quo, we have to recognize inflationary pressures.
You will not see rate increases in our budget except for mandatory rate increases that are mandated by the federal or state law. And so for us to stay within a reasonable budget, a 5.81% increase, the major pressures that the agency experiences are pressures in utilization and caseload. And so this year, particularly as we see some organizations that are healthy and some are not, we're going to work to try to fix the challenges that those organizations have before we continue to pour more money into those organizations. In the last 2 years or 3 years, we've put more than $212 million into rate increases across a broad set of providers. That has not fixed or solved the problem. And so this year, our goal is to look at the structural issues similar to what we did in DOC and work to try to address those structural issues before we continue to fund. And if we don't do that, then the agency is left to look at what services we are going to cut in order to make sure that we have a reasonable, balanced budget.
So just to clarify, the components that were being discussed in terms of these need to be increased in order to maintain services at the status quo because of inflation, all of those are exclusively things where they are mandated services.
We are making rate increases in the places where it is mandated this year.
There aren't any going to any non-mandated services. It's all mandated services in all of the state budget.
In terms of rate changes, that's absolutely correct. In terms of rate changes, those that are mandated either in state statute or in federal regulations are those that were adjusted. Otherwise, caseloads take into account current rate structures. And so the increases here reflect caseload changes specific to current rate structures.
But I'm not just talking about rate structure increases. I'm talking about all state expenses for services. Some of the things that are delivered by the state itself, state employees aren't under rates, are they? They're under, but they have budget pressures for inflation.
Yeah, there are budget in terms of the state budgets, the lights on.
Yeah.
There are
Good term. That's the term it's right. The lights on.
lights on. For rates for our providers, which is what was asked before, they are the same rates going forward this year. When it comes to overall pay act and other things that are included in the collective bargaining agreements, which you see with DOC,
Yeah.
those are included in our budget.
Is everything in those budget increases to keep the lights on, are they all mandated services? Federally mandated services?
In terms of rate increases,
No, in terms of the budget increases to maintain the status quo within the overall budget, recognizing the status quo requires inflation. I'm not talking about rates. I'm talking about all services. Is everything that's getting an increase to keep the status quo mandated services?
It's an array of all services, those that are both entitlement programs and those that are funded in a more discretionary manner. We did not make reductions to any discretionary programs outside of caseload adjustments.
I'm new, so I don't know.
Yeah, I didn't quite
Oh,
follow.
Council.
Yeah.
Okay, I'm sorry.
No, I didn't quite follow that in terms of what my question
Yeah,
was.
so representative, let me try one more time. And again, if we don't, then I'll try to reflect the question back. Related to most of the programs that we do through our Medicaid program are not capped programs. They are programs that the total amount that's expended on them are based on utilization. So that's there's rates, there's utilization, and those who are eligible for the programs. We did not adjust rates, but we did ensure that we adjusted up if we saw an increase in overall utilization, and we did adjust up or down depending on the number of individuals that we estimate will be enrolled in the programs.
But are all services provided by the state through,
Are they all?
Agency.
No.
well, are
Things like
they all,
dental.
are they all based on rates? Are all services the state provides through its different departments? Is everything based on rates, or is some based on direct delivery by the state through not rates, but through staff providing services?
So
It's a mix. There are services that are tied to rates and the provision of face-to-face services, so to speak.
Yeah.
There are also grants that are given to our community partners that are not necessarily tied to rates, where they are considered subgrantees and manage those funds on behalf of the agency. So it is a mix.
So in terms of the ones that are not grants or rates or
I think
sub-agencies.
what you're asking, let me see if I can reflect the question back to make sure that we're hearing it right.
Yeah.
Are there programs that are provided by the state, by state employees? For example, things like immunization programs provided by the Department of Health.
Yes.
Are there increases for those programs?
That are not, not mandatory federally mandated services.
So there are not program increases. What you will see, and I think your question is getting at, what about the cost of the staffing and other related expenses that are included in overall management and running of state government? And we can run through line by line if it would be helpful. We probably don't have the time today, but things like Pay Act, you will see that Pay Act is reflected in the agency's budget. Things like the services agreement that we have to run IT, that is also reflected in the agency's
And not
budget.
all of those things are federally mandated services. All I'm trying to say is I think there's a double standard. I think clearly there's a double standard. That's in terms of what gets inflationary pressures. And the rationale was it's only for federally mandated
So
versus.
again,
But when you take across the.
we could cut those services. And that's the decision that we were left with. And so I'm going to move on, if I may.
We have
services,
one more question.
in order to adjust for those. And that was something that we gave careful consideration for, is whether, regardless of whether it was a state staff-run program or a community-run program, in order to.
Only cutting services in community-run programs.
We're not.
In rate
Not
based.
cutting service,
Yeah,
yes,
we're
but
not cutting
yeah,
services.
rates, I know.
But
A flat rate-
indirectly, a
is
flat
cut in
rate is a
services.
cut in services. We all know that.
Yeah, okay, keep it brief, please, Representative Steady.
I'm new, so I don't know how it works. I've sat here a few weeks listening to testimony for H91 and H13. And I'm a money person, and I've seen substantial increases in dollars. One was $1 million just for new staff. So does that mean if these pass, the money won't be there?
We're not dealing with these bills.
Oh, I thought we were.
No.
No, this is the overall budget presentation for
Oh, but
HS for.
if these pass.
But
Totally
that's a
separate
different
thing.
question.
Totally separate thing.
I'm learning.
Thank you. I think the point that Representative Donahue was just trying to make is that community-based providers are not being treated equally to both state employees and certain other community-based providers.
Okay, moving on. Thanks. So in addition to seeing some of the increases that we've seen related to caseload and utilization, we've got the federal Medicaid, the federal FMAP, which we talked about here before, that the rate adjustment there has fell in our favor this year. And so we are seeing
$16.2 million reduction in general fund need and an increase in the federal participation as a result.
same thing in our Medicaid program with childless new adult caseload and utilization. Our child care financial assistance program, we're also making adjustments to caseload and utilization, and we've seen less utilization in that program. So we are adjusting to make sure that it moderates to what our current utilization and caseload is. Same thing with Reach Up, with the Family Services Division caseload adjustment, and with the DOC net vacancy savings.
So was there any consideration made, particularly in Reach Up, to decreasing the rateable reduction?
I'm sorry, couldn't hear you.
In the Reach Up caseload, there's calculation that happens and then we reduce it by 50% essentially. What we say is required to live and exist. And then we reduce it by 50% called the rateable reduction. Was there any consideration made in the context of this budget to, rather than, applying that essentially to some of the ups, to looking at, reducing that rateable reduction to something less than 50%?
That's not included in the budget, any change to the rateable reduction. So it's as you're well aware, it's similar to a rate question, so to speak, and
So there was no
the information we
consideration made.
provided earlier.
I would actually,
applies.
that is within the DCF budget.
Okay, we'll ask them
So I
specifically.
would ask DCF in terms of the decision-making around their individual budgets.
Okay.
Okay. So, moving forward, highlights again, after we adjusted for rates, for lights on, there was very limited funding that was available. And so we really focused this year on moving, on initiatives related to substance use continuum of care, as one of our key areas. It's been highlighted for the last few years that there are gaps within that current system of care, particularly that the residential treatment system does not always allow individuals to enter because it's based on clinical criteria, particularly when they relapse or if they're withdrawing, but not withdrawing and needing medical supervision. We also recognize the need to ensure that individuals transition seamlessly from residential treatment to outpatient care. And so what this $1.3 million does is it ensures that we are able to, with our current treatment providers, provide the full continuum of care so that individuals with substance use disorder can enter those programs when and where they need them. In addition to that, it is understood that there is for many of our individuals who potentially are experiencing homelessness or other have very complex needs, that being able to go to recovery housing is critical in their success with substance use disorder treatment. In this case, what we are doing is creating a campus. And again, this was with a lot of conversations and discussions with a broad set of stakeholders. We're working to create a 15-bed campus model, which allows us to provide recovery housing and intensive outpatient treatment in the same place and space. We know that having that continuum of care where someone lives is important, particularly for individuals who haven't been able to be successful when they either move between residential treatment and home or residential treatment and recovery housing. So again, this was a significant gap that many of our providers and clients asked us to fill. And so we are moving that forward this year. In addition to the base, there are one-time initiatives that are intended to support the startup of that program. We also recognize that in our correctional facilities, a key place in which more than 70% of individuals are getting medication-assisted treatment, that we need to enhance the care that they are currently getting. That right now, the main focus has been, and Vermont is a leader in this area, ensuring that we have medication-assisted treatment within our correctional facilities. And yet in none of our facilities are we providing the full residential level of treatment. And so this allows us to at least use one of the facilities and moving forward with one-time funds to both investigate how to do that and for at least one quarter to implement residential level of care so that individuals who are returning to their communities have a better foundation in their treatment and recovery.
Do you have a question, Representative Cole?
Yeah, maybe again, for maybe future day, but I keep hearing this from the administration, just that we have one of the best MAT programs in the country, and I'm just curious about where that came from and just more information on that. But that might be for a future conversation.
Yeah, I'm happy to take that offline.
Sure.
At any point. We also have the Department of Health likely coming into committee. They can talk through it. I would like, having been one of the folks who helped get up and going the hub and spoke program in Vermont, that was one of the foundations. So hub and spoke was a leader across the nation in which we began to both embed treatment using medication assisted in primary care and ensuring that in addition to Suboxone, that we had access to methadone for those individuals who needed more complex treatment, and that we, instead of having capped programs, that we treated it as an entitlement program. And so that was implemented now almost a decade ago in order to bring and expand medication-assisted treatment. Now, medication-assisted treatment in our correctional facilities is great for stabilization, but MAT paired with treatment has really been the foundation of Vermont's programs broadly.
Representative McGuire, I thought you had your hand up
Oh, no.
before. Okay. The Department of Corrections isn't really within our jurisdiction, but given that I'm on the Joint Justice Oversight Committee, I'm curious as about whether it's this residential treatment. You say it's within a DOC facility. So is the plan to sort of somehow develop a separate unit within a specific facility that focuses primarily on the residential treatment for people with substance use disorder?
That's exactly what the plan is.
Okay.
And that's why we need, because that's not really done much across the country. We're going to take the first part of the year to do that planning, to both look at the facility and the program to get that up and running in one of our correctional facilities.
Okay. Representative McGill and we're done.
Can you, and maybe you haven't gotten this far in your planning, with this, how folks wind up in that facility? Is that an option, a path they choose as in when they're incarcerated, or is that they're placed in that?
So treatment for substance use in our correctional facilities is voluntary, like MAT. This would also be voluntary, and it would be given an option. But, what we're trying to do is enhance options. What we know is that some of the individuals who are receiving substance use treatment need enhanced recovery housing more than what we have. We know that we need our residential treatment programs to be stronger. And we know that many of the individuals who are experiencing substance use are also involved in our correctional facilities and substance use there. In some of the cases, our goal is always to ensure that people are you'll often hear the lowest level care possible. So that's why pretrial supervision is paired in with the substance use, because what we know is that we want to ensure that people who are really struggling in the community still get treatment in our facilities, but we also want to provide the support and structure and supervision for those who who currently are in our judicial system and are struggling to continue to remain in the communities. So our goal here is to be able to like enhance our services and pair that with supervision and support so individuals can be successful in communities.
I just wanted to make sure.
It's voluntary.
Voluntary.
It's
It's, I mean,
voluntary.
treatment, we
It makes
need
it-
more treatment options, but it can have very dire consequences if treatment is not.
No,
Not
it's-
voluntary,
It's always
so.
voluntary. If someone comes into our system, into our correctional system, they're offered substance use treatment, assessed, offered substance use treatment. We just know that the main focus has been on medication, which is great for stabilization. But for those who really need more intensive services, our goal is to provide that while they are incarcerated.
Thank you.
I think you partially answered, but I'm still trying to clarify because we have the term recovery campus and there was reference to helping them find housing, recovery housing. This is only for people who are sentenced to a correctional facility, and this is how they're getting planning while there. This is not for anyone who's not sentenced to a correctional facility. Is that
There are
right?
three different, if you look on the slides, there are three different initiatives here to help fill the gaps. One of them, enhanced residential treatment so that individuals can get the care they need. The second is a recovery campus. That's recovery counsel, that's recovery housing paired with intensive outpatient services and overall wraparound support. And then the third, which is under one-time funding, represents
Thank you. Okay.
is working to convert a pretty significant portion of one of our correctional facilities to provide residential treatment.
Thank you. So the recovery campus is non-correctional system tied at all. Thank you.
Exactly.
Yeah, that's,
We want to minimize the number of like what you also see as us use the term campus.
Mhm.
We want to minimize the number of transitions that individuals have, and we want to do a better job at transition. So what you see here is trying to make sure that we get the full system of care in one place in both of these settings, at all three of the settings. Sorry.
So just,
I'm super excited about this. To be honest, it's the area where we know, like, mental health and substance use have been the areas where they have been high priority for the agency for the last several years. And we have seen great strides in mental health, particularly in our crisis system of care, with 988, mobile crisis, and alternatives to emergency departments, which we'll find on the next slide. And we've been assessing what the gaps are in our substance use system. And this is our movement forward to begin to fill those gaps.
while you were very excited about the term and the concept of campus, I am not. It harkens back to Brandon Training School and week school when you think about campuses and
that's why it threw me off that it was a
Institutional
correctional
based
campus.
service.
We're talking about the youth campus in Virgins,
Yeah.
Yeah.
right? That's,
Happy to change the language. The point here, and that language actually came from the communities that we've been working with, those folks who have lived experience. They wanted us to go and look at, and, you know, their families and other providers look at models in other states, which we've done. We've looked at Granite State. Again, not a force cut, but that's what they were using. Happy to change the terminology, but what they were trying to get at here, which I think is the most important principle, is they want to be able to go to one place and receive all of the care that they need so that it feels like it's more in line and more cohesive. And that's the goal.
yeah, I think maybe the more important one to change is to not call Virgins youth campus. Because campus does sound more college oriented. So maybe there's too many past
Too many
associations.
past associations, negative
but-
connotations.
But the youth campus, yeah, the youth campus for Virgins is, I think, really inapt.
The people who established Brandon Training School thought the same thing.
Mhm.
I mean, you know, hundreds of years ago when we said, oh, we can get all of these things in one place.
Again, we were going with folks with lived experience on this. I hear you, and we'll provide that feedback particularly back to folks. Okay. other initiatives that we are doing. Again, there is nothing new on this list. The place where, in this case, what we are doing is moving things from base, from one-time funds to base. This really continues to reflect where the priorities have been and continue to be. So it's moving what many people call mental health urgent care or alternatives to emergency departments from one-time into base. They have been covered by home and community-based services, one-time FMAP funding. And so this asserts our commitment to continuing to keep them going and ensuring that they are accessible across the state. Again, it's also the annualization of the current shelter expansion. We asked our shelter providers to expand. And so this is our commitment to continuing, as we know we need those shelters to keep them going. It's also scaling programs up. What you see here is for the last year, we've been piloting pretrial supervision in one county. This allows us to add an additional county, again, to evaluate what's going on. And that's, I think, a key theme here. We are keeping programs moving that we have evaluated and that are successful. For example, the mental health urgent care, between the combination of 988 mental health urgent care, the stabilization of the Brattleboro retreat, and mobile crisis, we monitor the data every week, and we've seen that system flow working. People are not in emergency rooms for as long as they were. They're getting the care they need outside of the emergency departments. We're seeing less use of that. And so I think that's why you begin to see these investments continuing our commitment and what we've already done. In addition to that, for one-time funding, it's the continuation of the PCB testing. Department of Health can provide more information on that if necessary. It's ensuring that we have emergency shelter beds for next year. And what we've seen in primary care is that they are confronting the loss of several different funding streams this year. They have got the loss of the Medicare funds coming into the state for primary care for the Blueprint community health teams, which are the basis for hub and spoke, and the basis for advanced primary care. They are losing payments through the ACO, and the ACO that were payments directly made by the ACO to primary care. They're losing a program called comprehensive primary care. And we've been working for the last few years to expand mental health options in primary care. That was a one-time pilot. This $10.8 million is a commitment to continuing to address that funding, that a portion, not all, but a portion of that funding gap. It also allows us to keep STASH going in this gap year, which is a Medicare-funded program in the state. And so those are the other initiatives. So again, this is a current services budget, very little additional funding into very limited additional funding into new things, but instead really focused on what our priorities have been and currently are.
Thank you, Secretary. I am glad to see the 3.3 million for annualization of the shelter expansion because, as you pointed out, that was done with one-time dollars and it's expected that they will continue to be needed. So that's good. Anybody have any additional questions for the Secretary at this point in time? Recognizing that we'll delve deeper into this with each department, and we appreciate the broad overview. And while we might disagree about whether this is a current services budget for everybody, we recognize that that's interpretation.
Well, again, we'll be working with those organizations. So we have to make decisions either, so we don't have to cut services.
So you referenced the structural issues in community-based providers. What structural issues are you referring to?
Yeah. So in the last couple of years, and many of you probably know that we've had emergency financial relief funding that goes beyond the PNMIs, the private non-medical institutions, which provide residential care typically for children, and skilled nursing facilities. What we have seen are a number of different types of organizations who come through that program. And while many of their peers are healthy financially, the organizations who've come through really do need, in order to continue to provide service to their communities, have needed financial funding. What we have seen in there are examples of services that they are outsourcing, that they recognize that they can do better internally. What we've seen is that they might not, primary care is a perfect example of this. They are overstretched in their locations where they are. And so in primary care, as an example, they might have half the number of physicians in the practices because this is not just a money thing, this is also a workforce issue. And so they have half of the number of physicians that they would normally have, and yet the rent is the same. So they're getting half the revenue and the rent and the other fixed costs are the same. They're less than 5 to 10 miles from other practices in the same organization. And so we're seeing consolidation. We've also seen that each of them has costs that they could share with other organizations. And those are examples of where we've been working with those organizations to be able to share costs. That might be, do you share a CEO or CFO or a back-end accounting office? Are you working to negotiate some of the supplies and materials? Those are examples of what we've worked with organizations in our extraordinary financial relief program. And for every single one of those organizations, we do an assessment of their books to see where they might be losing money. We assist them in creating a sustainability plan, and then we give them the money that they need to get back on their feet. We have not seen the -1. We have not seen those organizations come back into the extraordinary financial relief program. That for us has given us some insight into where some of the structural challenges are. And so again, our goal is to work with is to dig deep, to work with the organizations to identify what the structural challenges are. Some of those may be rate methodology that we need to address going forward, rather than just the actual rate itself. And so our goal would be to dig deep this year and to identify where we can support organizations in addressing the structural changes that they have, the ones that I just talked about, and also looking at the rate methodologies for some of the organizations to make sure that they are incenting what we want, rather than incenting and or making it challenging for those organizations to survive.
Okay, any other questions for the secretary at this point in time? Thank you very much for being here this afternoon. Appreciate the dialogue. We'll continue on with it, obviously, for the next few weeks, and appreciate you being here.
Appreciate your time.
Thank you.
Okay, folks, after floor, you have time to work on your budget assignments after floor. And then we'll see you.